Hello, everybody, and welcome to this week's podcast on Fit as a Fiddle. I have the lovely Dr. Madhu Bagaria here with me today in our recording studio. Dr. Bagaria is an endometriosis excision surgeon. She's an expert on all things endometriosis, and she works with Pelvic Rehabilitation Medicine. So welcome onto the show today.
Thank you. So as Sneha said, thank you, Sneha, for inviting me today. And it was really wonderful to talk on this subject, which is very close to my heart. So I am an endometriosis excision surgeon. I finished my fellowship at Mayo Clinic Arizona last year in June, and just started working with this group at PRM and starting in September. And it's a wonderful group because it's an umbrella where you find care for endometriosis people, because we need to provide them the care, which is not only limited to surgery, but also they need rehab in terms of public PT and physiatry help, and nutrition and mental health, which is all available under one umbrella. So that's very, very important.
Yeah. What made you want to get into this field in the first place?
It's a long story. So I trained in India and did my residency, and then wanted to excel in minimally invasive surgery. So moved to US, did my residency again, and I worked as a generalist for 6 years at Mayo Clinic. When you work as a generalist, you deal with women in all walks of life. So I dealt with them, and I found women who were coming with pelvic pain, and in my teaching, if you have a pelvic pain, we think of endo and we take them for laparoscopy, but often we have a negative laparoscopy. I went to a postgraduate course and learned about checking for pelvic muscles and nerves, and that was very, very good for me because it was an eye opener for me, and I started doing it. And believe it or not, my colleagues thought I was crazy, like doing all this and not doing laparoscopy on these patients. And I collaborated with some PTs, and I found some very good results with most of my patients. They were doing really well just with physical therapy. And I think it's also the mindset in some of the patients that define PT as like, what is PT going to do? But in my mindset, I'm thinking like I'm doing good for them. And sometimes, it's a hard part for them. And then I wanted to venture more, like injections and all those things. And while I was in my 6 years of tenure, I also took care of patients with endo. And one of the patients had very bad endo, and I knew I could not take care of her. So I had to refer her. I just put her on dapagliflozin, which was it killed me from within, like I could not help her. And she was in pain, and she was an immigrant with not much resources to afford. And then I did surgery on someone which was incomplete, and that day I was like, oh no, this is not me. I need to further improve my skill set. I also dealt with some chronic pain myself, and I know that how our patients go through what in the mind is going on. I understand each MRI is not just an MRI written on a piece of paper by a physician. When it comes to a patient, it's a lot of mental thing which is going in the brain. It's not easy to just say, hey, get an MRI. We have to think from patient's perspective of what is going on. And when you see a person, they look very healthy, but you don't know what's going in the brain. So all these things, chronic pain, chronic pelvic pain, when I saw all these patients in my journey myself, I felt like I needed to improve my skill set. And that's what made me push. Like I ventured into fellowship again. And I was lucky enough to got a position at Mayo Clinic Arizona. And there I trained with the best of the best. So very lucky in that aspect. And Mayo is a very good center with tertiary breast center, and we saw all the breasts and all varieties of endo, and it was an eye opener how gratifying this is. So it kind of built up on me, like yes, fibroids can be done with anybody. Yes, you can do endometriosis, but to do a good job of endometriosis and to see these patients recover was very, very gratifying. Like I could see that how it brought tears in the eyes of patient when they came to the physician and they were feeling well. It is really something like as a woman, we need to understand women better and need to provide more better care for them and understand the team approach.
I love all of that.
It is very dear to my heart.
Yeah. I think like the best part of everything that you said is how gratifying it is to see the patient's results, because even as a pelvic floor PT, the best thing that could ever happen is a patient who's really, really benefiting from not only the work that you're doing, but the work that they're doing because of the guidance and the research and the experience. And that's what just keeps us.
Yeah, and we have to understand that you cannot just work in a silo. Like, yes, as a surgeon, I can do surgery, but that's not what is going to take care of your pain. Pain, when it comes to, it's like an onion, as I say, it has several layers, and you have to peel the several layers, and you have to get in the mindset. Okay, surgery is one thing. As like, you know, in the modern day society, we are very like, we want quick results, and we think that surgery is going to provide you quick results. It's very, very important for people to understand that surgery is just one aspect. Prehab with the PT, post-hab with the PT, these are very, very important things. Mental health is very, very important. And I'm not saying that you're crazy when I'm talking about mental health. And I can sense that it's not in your head, but we also have to work on de-escalating the brain sensitization.
Absolutely.
Because we go in a negative path and we don't even realize that we're going into it, and this just keeps like a circle.
Yeah, totally. What do you think it is about endometriosis that seems like such an enigma that's like difficult for the general medical population to fully grasp or be able to diagnose, or even for patients to, like, what are the biggest barriers that seem to be present for people to be able to get care?
There are many. I think there's lack of research in this aspect. If you look, even now, when I hear from patients, like when they complain, when they come with these concerns are just brushed off, or if they say that you have endo, they just say, go and have a baby. Like yesterday, I saw a patient who was telling me that I went to so many different gynecologists, and they told me, go and have a baby and your body will reset yourself, or all the hormones will get resetted. So I think the symptoms are so vague, except for the painful periods, which we are all told from the very beginning that tough it out, all women have to go through it. Tough it up, and like, you know, we are just told tough it up, like it's fine. So the symptoms of like the diarrhea symptoms, the GI symptoms, and nausea symptoms, we're just told that this is in your head, or this is just going away and you're just making it up. So that's one thing. Painful sexual intercourse is something which women find very ashamed to talk about.
Absolutely.
They don't want to talk about a urinary symptom. They don't want to talk about bowel symptom. They don't want to talk about painful intercourse, and such an intimate thing. They don't want to talk among themselves as well, you know. So those kind of things prevents women in getting care. And I say our education system is also at fault, because my training as an OBGYN was not that intense in endometriosis. As a resident, it was not that intense in endometriosis. And it's difficult for them to know how to recognize it. And if they recognize it, the skill set which is needed to remove this disease is also very limited. So I think overall, and all the research which you see in for endometriosis, they are kind of old research. The excision as a surgery came recently into the limelight. So the research with respect to what is the long-term outcome of excision surgery itself is lacking. You know, most of this, if you think about all the previous research is based on ablation and mixed, you know, it's not, and everybody's doing it. So the same surgery is being done by generalists, it's done by any gynecologist. But now, like, we know that in previous time when we had cancer surgery, if cancer surgery was done by generalists, they have a poor outcome as compared to cancer surgery done by GYN-onc, because they do a complete surgery. So now it's a time, I think, it's a time to wake up and start doing research more in this aspect. The pathophysiology, we all know that the pathophysiology, we think that it may be because of Sampson's theory of retrograde menstruation, we think of this and that, but now we're thinking in terms of genetics. We're also thinking that women are born with this condition in their mother's womb, and then something happens during the life when these cells just become triggers and they start forming these cells. So we know that endometriosis is not endometrium, so that is very, very important thing that Dr. Redwine had started initiating, and I think we just need to build up on our things so that women can get the care they need.
That's great. For anybody who's listening who might be like, I don't know what you're talking about. I thought endometriosis was just, you know, endometrium tissue outside. How can you kind of describe this new understanding, and how can you help people kind of reshape the way that they've thought about this disease, even for themselves before?
So initially we used to think for how endometriosis developed is that these cells that when women menstruate every month. So if you have a uterus, there's a fallopian tube, and there's a connection of the uterus with the fallopian tube to the abdomen, to the belly. So when you menstruate, some of the back pressure goes, and these cells, so the endometrial tissue which is shed every month is actually flows retrograde into the tube, and it sheds into the abdomen and it implants. So we used to think that this is cells, this is endometrial cells, or this is endometrial tissues which is actually shedding. And that was a very very well accepted theory called Samson theory. Even now in textbook you will find it. But now we know that this endometriosis is not endometrium. It's not the endometrial cell, but it's cells which is similar to the lining of uterus. And we say similar because it still responds to the hormone, but it's not the endometrial cells. So that's one thing we need to understand. So that's how we say that it is similar but not similar, you know.
Got it. And then also for people to just understand and just wrap their heads around endometriosis versus adenomyosis, the sister kind of conditions. Can you just give people like the current like medical understanding of the difference between that as well?
Yeah, I have a very easy way of explaining it. So I say that they are evil sister conditions, right? They can coexist with each other in 80% of the cases, but there's similar things. So if I tell people like, and both of them are cells similar to the lining of uterus. So if they're in the muscle of the uterus, so if they're living in the home of the uterus or in the home, there's adenomyosis. But if they're outside the uterus, that endometriosis, and can be anywhere in the pelvis, in your diaphragm, in your lungs, in your bowels, anywhere. So simply said, they're both similar things. They both perform the similar action, although adenomyosis, because it's in the home, it causes more menstrual issues, but they cause similar symptom, but they're different in a way because we just want to say, okay, if you're in New York, you behave like you will be called a New York, or if I'm in New Jersey, you will be called a New Jerseyite or Jerseyite, but you perform the same things. So it's an intruder is inside your house. If it's living within you inside your house, it's called adenomyosis. But if this intruder is living outside your house, will be called endometriosis, but both of them are intruders and both will create mischiefs.
Yeah. When a patient comes to you and, you hear their subjective history, typically, I'm sure you'll hear them say things like, I've been going through these kinds of symptoms for many years. I've been misdiagnosed and I've seen this doctor and a GI and a colorectal and a GYN and blah, 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 all these different professions. And they'll say, and we've kind of realized after 8 years or whatever that I might be having endometriosis and that's why I'm here. What are some of like, I guess the top 3 or top 5 like things that red flags that you can hear in a patient's history that will make you think this is endo versus some other condition like a chronic pelvic pain or something that's more so like dermatological or that's less so the hormonal tissue growth?
Okay. I think recently we shared a patient with you, which I was like, hey, I think it's more muscular. So she came to me because of pain, which is exercise. And her menstrual cycle was totally normal. And she was telling me that I have only pain with exercise and so all lower pelvic pain. And it was like, okay. So it's basically start with a good history taking. And sometimes when I talk about pain, then when you're talking about pain, you look about what are the symptoms that aggravates it, what is the symptom that relieves it, all those things. So those are important things. What is the level which gets to? Those are important things. Cyclicity, although we know that endometriosis pain may not be cyclical. So sometimes when you talk to patient, you get a hunch that this may be more muscular. Well, you can be wrong, but you've just made the guessing work also. The thing which flags me is like, when there's a constellation of symptoms, basically, yes, you have low abdominal pain, but you're also giving a history of painful menstruation like cycle. And sometimes if your menstrual cycle to the point that you're missing school, so I always ask patient, are you missing school? Are you missing work? That's very important for me to know because then I know the intensity of the pain is so severe, which normal menstrual cycle should not be that painful. Or if they're having nausea, or they're throwing up, or they're associated with diarrhea, bowel symptoms, and things like that. I had one friend who was having severe pain with bowel movement. You should not have severe pain with bowel movement, although, and you must have gone to GI, and you've ruled out fissure and everything, but still, you should not have this monthly cycles of painful bowel movement. The other thing, which is like painful intercourse, again, intercourse should not be painful. If it is painful, you think about pelvic floor muscle spasm and you think about endometriosis, but we know that endometriosis itself can cause pelvic floor muscle spasm. So these are the things you need to rule out. Women who goes to urologist frequently because they're having this frequent UTI and nobody could figure out, and their urine culture is all negative. An important thing. I also ask people like, when hesitancy, like they're not able to relax themselves, things like that. And IBS kind of symptom when they're going and they're telling that, oh, this is IBS, but it may not be IBS, it may be related to endometriosis. Again, it's a constellation of symptoms. It's about taking a good history. And some of these can predict, what is going on. Infertility, like unexplained infertility, we know that it can also be associated with endometriosis. So it's very important to take a good history and come to the conclusion. And sometimes, when you treat so many people, you also get a very gut feeling as well. Like I had for that patient, like this is all muscular. I don't think this is endo.
Yeah. You just mentioned IBS is also like a disease of exclusion in some capacity, because what they'll do is a whole bunch of tests, right, to determine like what's going on with your gut. And if really there's nothing going on, they'll call it irritable bowel syndrome. And you can either be constipated on that side or on more like the diarrhea side. So it's basically like this big umbrella term for something's wrong with my bowel, and nobody can figure it out.
Yeah, and again, like, you may get your endometriosis evaluation may be negative for that as well. Again, we have to come to like, okay, what are other causes? And I also think of mind-body's connection. I also tell people about these things, think about these as well. So yes, you can go for surgery, taking the evaluation, because it's very, very important for you to know, because it's a diagnostic and it's therapeutic when we go for evaluation, because we need to make sure that you don't have it. And if you have it, we need to remove it. Yeah.
And what you're describing is basically like the gold standard of doing surgical excision, which is what you are trained very well in. And so for the audience listening, if we've gone through the subjective history and we've really ruled out some of the other important things, then what a surgeon like Dr. Bagaria would do is go in and check laparoscopically to see if there is true endometriosis, and understand what the tissues are doing by taking a biopsy. And if there is a problem, then you're gonna fix it.
Yeah.
And the idea is to fix as much of it as we can, because we know that there can be
and the idea is to get one surgery, and that should be your last surgery, because we know that the outcome is much, much better in the first surgery. So, do it once and do it right. That's a bit over, because we know that people with the first surgery, they have a good plane. Nobody has touched. Like if they go for ablation and all the tissues becomes more fibrotic for them. And again, they're risking their thing they're undergoing through so many surgeries, and we know that repeated surgeries is not good.
Exactly. And then after this surgery, and even before the surgery, it's really important to make sure that you are getting proper treatment with pelvic floor physical therapy, because muscles respond very, very well when they are both manually, worked on, not just the pelvic floor muscles, but the muscles around the pelvic girdle, around the abdomen. Because as we know, and as Dr. Bagaria just said, those like the tissues can actually be disrupted all the way up into the lungs. And so one of the big things we work on is understanding how to do diaphragmatic breathing and proper excursion of all of the muscles that are surrounding the uterus, from here to all the way down to your hips and below, and making sure that your whole body is moving in a way that's working for you. And that looks a little different from patient to patient. So the pre-rehab and post-rehab of doing physical therapy can be really beneficial for a lot of people. In your experience, what have you felt patients tell you in terms of whether it was nutrition or any of your adjunct kind of like the colleagues that you work with? What are some of like the top people that they need to be seeing in order to get holistic care, other than physical therapy, of course?
So I think apart from that, I tell people like I often steer them to building a social connection around them, because nothing can be more supportive than your social friends, like who pulls you up. So I often tell people, like, surround yourself with people who lifts you up. Even it can be like a YouTube TED Talks. I know that there are certain TED Talks on YouTube, like with Linda Rankin, she talks a lot about mind body things, because then they find hope. They find things which helps them. I refer them to Curable app, where they can find social support and community. I also refer to them SIRPA. It's a SIRPA UK. It's a UK based thing. They help people, a lot of people with chronic pain. So these are the things which they can do at home without being so much expensive, right? The other thing which they can do, I often stress the importance of good diet, and the diet is not to cure endometriosis. It's just like, we know that food is medicine, and whatever food you take, it affects your body and overall well-being. If you eat food which makes you more bloated, and you're already bloated by endometriosis, that's not going to work in the right direction. So eating a good diet, and I tell people not to invest in like a very what do you want to say, like a keto diet or things like
Fad
that,
diet,
like
yeah.
fad diet. I tell people, like, listen to your body. Your body will tell you if you eat gluten, and if it tells you not to eat gluten, then stop it. But if you eat gluten and you feel fine, that's okay. And eat from your kitchen. Avoiding processed food is one thing which I always tell them, and eating from the kitchen is something which I always stress to them, and eating more fresh rather than buying canned foods and canned products, Those things I stress to them. If they feel good with acupuncture, yoga, Pilates, good for them. It's also good for your mental health as well. So I'm like okay with any of those things. So I don't impose them that you need to do all these things, but these are good for your overall, like taking care of yourself. Self-care is important. I think these can be important. Doing what you like. So even if it's a stroll in the nature, it doesn't cost you anything, and it could be very good for your overall well-being. I tell them about exercise snacks a little bit throughout the day. Movement is good for your body, and it makes you feel overall well. Even it means that you have to push yourself initially for 1 or 2 days, but then eventually when you get in the flow, you feel better. I just tell them to celebrate each little success they have in their life. And as women, I tell them to pat themselves on the back because they've gone through a lot. Even going through this, they're taking care of the kids, they're taking care of the parents, they're taking care of the food in the house, they're running errands. I tell them that you're very brave, and pat yourself in the back for all these things which you do in everyday life. I don't have a top 5, but I tell patients to recognize those things and do whatever feels right to them. Because I know I don't want to be like pushing them to do this, and we know that everything is expensive. So whatever feels right to them is the best thing. 2 things which is important for me is the physical therapy. They cannot negotiate with that because I think they will need it. And physiatrists, like we have physiatrists in our group, and they do a wonderful job in medical management and those things, so they can do that too. But otherwise, other things I think as and when they feel like they can do it.
I love that. I like the exercise snacks. I might be using that with my patients too. Dr. Bagaria, is there anything else you want to add regarding endometriosis or the work you do, or something you would like to share with patients that we haven't covered already?
I feel like, endometriosis, I'm very thankful to the social media that it is coming to the limelight and more people are accessing care. I feel that as women, we need to stand up and voice for these things, and understand what women is going through and help them to the best possible way we can. And I think we all play an important role, and let's be in it together.
I love it. Well, thank you so much for being here on the show today. If people want to find your practice or get in touch with you, what's the best way for them to do that?
That's a PRM website. They can go through there. I have an Instagram account. They can message me directly through there. And I think the phone number in the office will be fine.
Perfect. I'll put all of that on the show notes. Everyone, I hope you gained something from today's episode here on endometriosis. It's something we haven't covered on our podcast yet, so I'm really happy after some hundreds plus episodes, we're finally having the right expert here to talk to us about it and shed some light onto this incredibly important and under-researched and underdiagnosed condition. We hope that people find this information useful, and please get in touch with Dr. Bagaria if it sounds like any of this information resonates with you, if you have questions, if you're a prospective patient, or if you just want to get more information and learn more about some of the other things that they do at Pelvic Rehab Medicine. Thank you.
Thank you.